So this is my fourth video of 4, and these videos are a brain dump, which are designed to put all my urological knowledge that I have gained in the last 10 weeks over my intern rotation at Ballarat Base Hospital onto paper and video so that I can remember it in the future, just for basic knowledge. Now, these videos are designed to be an educational reference on myself, but I hope other people will find it useful. This final topic we're going to cover is prostatomegaly and what to do in the case of someone who comes in with a typical symptom of urinary retention. So, prostatomegaly usually causes what we call bladder outlet obstruction, and this is where the prostate here gets so big that it starts constricting this urethra, first of all causing lower urinary tract symptoms, terminal dribbling and poor flow, hesitancy, straining to urinate, but ultimately causing the pinnacle of urinary retention. So you may have a patient who comes in with a male patient who comes in with a big bladder, do a bladder scan, and they've got 800 mils, 1 litre, 1.5, maybe even 2 litres in their bladder. And this is obviously very uncomfortable for the patient. The first thing that you need to do is relieve their primary complaint, which is the urinary retention. And you do that by throwing in an IDC in. Put an IDC through here. It will usually traverse the prostate quite easily, and then you'll relieve that obstruction, and then urine will start flowing out with a big relief by the patient. Big relief. This catheter usually stays in there for 2 to 3 days, and then you can do what we call is a trial of void, or taking out the catheter to see if they can start peeing again. The rationale behind this is that by giving the prostate a bit of time to not shrink but to be controlled, I suppose, then you could have passage of the urine much more easy through the urethra and out. What will usually determine whether you pass or fail the trial of void. Pass trial of void means that you can pee properly. Fail the trial of void means you've taken out the IDC, they've started building up urine again, and unfortunately they've still got plenty of urine in their abdomen, and they go back into retention, which is unfortunate. Big determinant which I've found is whether it's painless or painful retention. In painful retention, these gentlemen are usually younger, and they have smaller volumes in their bladder, so maybe only 800 to 900 mils. Still a lot compared to you or me, but much less than those in painless retention. So painful retention, they'll have a lot of pain. That means that the sensation in the bladder is still intact, and the bladder can contract well. In these cases, if they have painful retention and they pass their trial of void, so if they pass, then that's all good. They can go home, and hopefully they won't have to come back again. If they fail their trial of void, or they have passed before and then they have come back the second or third time with acute urinary retention, then usually we proceed to operative management, which is a TURP, or a transurethral resection of the prostate. Rationale behind this is that you core out the majority of the prostate, you allow the rest of the urethra to have a lot more room for the urine to flow through. Everyone's relatively happy. Side effects of these are retrograde ejaculation. You can also get some degree of incontinence as well, although much less than prostate cancer. An interesting thing is that when you take out anything from the body, including a transurethral resection of the prostate, you send it off for histology. And if you find that these prostate chips, which you've resected, contain prostate cancer, unfortunately you have to go back in, and you may have to go to a radical retropubic prostatectomy. That's why it's really important in someone who both has acute urinary retention but also may have prostate cancer. It's important to find out what kind of prostate cancer it is, because if it's a say, Gleason 7 or high-grade cancer, then you are going to take out the prostate anyway. Whereas if they have low-grade cancer, you can do a TURP first, which is just resecting the majority of the prostate, and you don't have to resect the rest. The worst case scenario is if you don't know if they have prostate cancer or not. You do a TURP, you send off the prostate chips, and you have Gleason 7 cancer. Then you have to do another operation, which is the big radical retropubic prostatectomy. And those with painless retention, these gentlemen tend to be older, and they have a much larger capacity bladder. So they might be holding 1.2, 1.5 litres of urine in this bag here. And this means that the nerves are not intact anymore. So that even when you put the catheter in, you can take the catheter out, but the bladder cannot contract because of this chronic urinary retention. And this means that they're going to fail. They're going to fail their trial avoid. So if they fail their trial avoid, then what are the options? Well, some people might say, oh, okay, you can do a TURP. You can try and resect this prostate. That will help the urine come out. I guess theoretically it would, but the driving factor behind why you would not do a TURP is that this large atonic bladder cannot contract anyway. So you'll take out the prostate, they still won't be able to void, there will still be acute urinary retention. So in that case, if they have painless retention, then you've got a few different options. You've got what we call intermittent self-catheterization, which is essentially passing a catheter into the bladder 3 to 4 times a day to pass the urine that way. In the elder individuals, like who are blind or aren't particularly good, then they can't do this. So the other option is a permanent IDC. So this is just a catheter, but just leave it in there for 6 weeks, 8 weeks at a time, so that the urine can drain naturally. An IDC can also be uncomfortable. So the other option is an SPC or suprapubic catheter, which is much more comfortable, but requires probably a local anesthetic to insert into. Now, the other options that you have if you don't want to put in a catheter in, I've come across these a few different times. First one is a memocath. Memocath is essentially a prostatic stent that keeps this little vessel open. And it's been very dodgy in my experience. The one patient that had it, the memocath slipped, so it slipped forward. It slipped forward and anteriorly this way, so that the prostate, which was the proximal prostate, started closing over again. So he was in urinary retention anyway, as well as the memocath being in situ. So there's a fail there. The other option is a urolift, which I haven't seen before, but I've heard is that you take you essentially get a few sutures, and then you tie the prostate back, allowing a clean channel for urine to pass through. And I think it's still largely experimental, but can be used in gentlemen who are too unwell to have a TURP, but would like something to be done which doesn't involve keep having a catheter in situ. So that, in a nutshell, is prostatomegaly.